Hello, everyone. My name is Dr. Abhijit Lele. Bring you greetings from Seattle in US. I'm a professor of anesthesiology and pain medicine and neurological surgery. And it's my distinct honor and pleasure to present to you the findings of our recently accepted paper in the Journal of Neurosurgical Anesthesiology regarding the neurocritical kit delivery during the SARS-CoV-2 pandemic. Here are my financial disclosures, none of which are relevant to this particular talk. Just a grim reminder for everybody that we are still continue to be in the midst of the pandemic. The total number of global confirmed cases exceed more than 250 million and more than 5 million global deaths. But the good news is that many of us are starting to get vaccinated. This data is as recent as a few days ago on the WHO COVID dashboard. And you can see here, many of us in countries that we live in are equally affected by this pandemic. And this is a snapshot from the WHO's website with regards to the death counts across the world. As you can see, there are certain areas of the world that are more impacted with regards to mortality than others. But nevertheless, we have all felt the impact of the pandemic one way or the other, personally, as well as for our patients in the neurocritical care unit. So let's talk about our study. Our study is titled Perceptions Regarding the SARS-CoV-2 Pandemic's Impact on Neurocritical Care Delivery. This was a global survey, and as I said, it was just accepted for publication in the Journal of Neurosurgical Anesthesiology, and the article is in press. Here is a list of our working group members. This was a multidisciplinary group of physicians, nurse practitioners, nurses, pharmacists that represented many, if not all, geographical regions around the world. Many names here you may be familiar with. Our main purpose was to get a global representation of hospitals that would report to us regarding their changes made to care delivery for the neurocritically ill patients at their own institutions. So you can see here the hospitals come from North America, South America, Asia, Middle East, Europe, Africa, and Oceania. Altogether, we gathered data from 253 hospitals across 47 countries. The way we set up the study, it was a pretty lengthy survey questionnaire followed by a semi-structured interview from one provider from each hospital that was intimately familiar with the changes that were occurring at their institutions over time. This study took place from the months of June 2020 to March of 2021. This is a busy table, but kind of gives you some of the differences in the way we looked at the data across these institutions. So we divided the institutions into by World Bank characteristics such as low middle income countries versus high income countries, by their virtue of their either dedicated neurocritical care unit versus a mixed general critical care unit, and whether at the time of the survey, the hospital had witnessed or experienced the surge of COVID-19 patients. So we were able to make these our three main categories: World Bank designation, dedicated or non-dedicated neurocritical unit, and surge of COVID-19 patients. So what we found specifically with regards to the surge, that those hospitals reporting first surge of COVID-19 patients saw a larger proportion of the hospitals experience conversion of NCCU or general critical care unit to a COVID cohorting ICU. Many hospitals converted non-ICU beds, such as the floor beds, ER beds, operating room beds, into ICU beds. And in many hospitals, the neurocritically ill patients were cared for in a non-neurocritical care unit by neurocritical care clinicians. But there were also deviation from standard pharmaceutical practices, because many of the drugs that are critical for our neurological patients or neurosurgical patients, such as antiepileptics, analgesics, sedatives, were in short supply during the surges. When it comes to differentiating these changes by World Bank income level, low middle income countries saw a reduction in general critical care or neurocritical care admissions. Patients who were neurocritically ill were cared for in a non-neuro ICU and by non-critical care trained clinicians. There was a lack of surge preparedness. There was a deviation from standard pharmaceutical procedures. There was cancellation of didactics. There was use of telemedicine. But most importantly, the low middle income countries struggled to add negative pressure rooms or modify existing rooms to accommodate COVID patients. And most importantly, they were struggling at the time of the survey to return to pre-pandemic standards. And as you can imagine, that the surges were different in different hospitals, different in different geographical regions around the world. Some had a huge spike and then a quick drop. Others had a slow spike and a longer tail, if you will. So you can imagine that these struggles continued for a much longer period of time, depending upon where you were in the world. Specifically with regards to dedicated versus non-dedicated neurocritical care units, conversion of neurocritical care units was less likely in those hospitals which are dedicated neurocritical units. So the physicians, the clinicians made their level best effort to preserve the unit for the neurologically or neurosurgical critically ill patients. Patients also were more likely to be on non-neurocritical care units, but cared for by neurocritical technicians. So this is important to remember that, let's say, for example, at Harborview, we have a neurocritical care service. So our group of clinicians or physicians, nurse practitioners, we may go around the hospital seeing patients like such as stroke, TBI, spinal cord injury, which are in any ICU bed in the hospital, but have a neurological illness. Many hospitals in the US or around the world may be geographically located even by service. So for example, a hospital in the Midwest where stroke patients are only situated in one part of the hospital now had to be moved out of that unit to make room for the COVID patients. So naturally, it's not the physician team that's important, but also equally important is nursing. And we'll see in a few slides about what was the impact of nursing care on patients with neurocritical care illnesses. And research shutdown was seen more in units which are dedicated neurocritical care units, hospitals with dedicated neurocritical care units. If you look at the characteristics of surges reported by the hospitals, many hospitals by the time of the survey, by around September or October of last year, had 2 or more surges. And even to this date, there were significant surges experienced by hospitals worldwide. Many hospitals reported that they were better prepared with the second and subsequent surges. So the first surge taught them a lot of important information. Most importantly, how are they able to deal with these surges? And that made them better prepared for subsequent surges. And they were able to better cohort patients with COVID-19 illness in the hospital, because now they were kind of familiar with how the infrastructure would allow for these separation of patients across the hospital. Some of the hospitals did report that there was inadequate ventilators or ICU personnel or staff to take care of patients with COVID or with neurocritical illnesses. And some of them also experienced drug shortages during different surges. Many of the hospitals reported that as far as the research and academic missions go, so we all in academic medical centers always look for promoting our knowledge and enhancing our knowledge to our newer generation of neurocritical care clinicians or physicians. So in these institutions and across the world, COVID research is prioritized. You may, just like this particular study looking at COVID specific impact of neurocritical, many of us embarked on various research projects that were focused on patients with COVID-19 disease. But during the initial surge, research was pretty much completely shut down because our research coordinators were not allowed to be in the hospital, where only essential healthcare workers were allowed at that particular point in time. And then subsequently, the research shutdown ended, and then we were able to enroll patients in clinical trials such as the BOOST or other trials that are going on around the world. Students and resident didactics were also affected, especially toward the end of the academic year last year, where many students were not allowed to be in the hospital. Many residents or fellows were unable to complete their residency or fellowship in their own unit. They had to take calls for COVID ICU, and that impacted at least the last few months of their academic year. And by and large, productivity suffered because many of us clinicians were asked to help out other colleagues in the COVID ICU. And so perhaps, even though COVID research was prioritized, only a few of us could really produce academically and papers, and many of us had to work more clinical hours. But many of the hospitals reported that by the time September, October, and March of this year rolled out, that research was back on track. And very few hospitals said that they really didn't have affected academics or productivity. So let's talk about what our survey participants reported as a significant impact of the pandemic on neurocritical care. So many of the hospitals reported that they did not divert patients who had neurocritical ill. So this is important to know that amidst the pandemic, as you're getting a lot of COVID patients coming to your hospital, you're also taking strokes, subarachnoid hemorrhage, TBI, spinal cord injury, neuromuscular disease. They're all still coming to the hospital, and many hospitals did not divert them, perhaps because they couldn't divert them. This was the tertiary quaternary care facility that many of these patients come to. So they maintained the workflow of those patients coming into the center and taking care of them. Very few people said that they had to be very selective in the admissions process. And that created a lot of conflict and a lot of challenges, which patient to accept, which patients do not accept. And some hospitals, especially in the low middle income countries and even in the United States, said that added negative pressure rooms or retrofitted exhaust systems were possible or not possible, depending upon which hospital and which geographical region you belong to. A common theme that's emerging from this study, as well as several other studies published before, is about burnout and low morale that are experienced by many of our healthcare providers, including physicians, nurse practitioners, and most importantly, our nurses. Many of our faculty and residents were diverted to the COVID ICU, like as I mentioned, to take more extra shifts to take care of COVID patients and help our colleagues in pulmonary critical care or general critical care. There was obviously reduced scheduled surgeries during the first surge, but then subsequently all the surgeries came back on track. And many of us had to go through this process of surges with the same amount of patients coming in with our elective or semi-urgent, semi-elective procedures. Family visitation was affected. As you all know, we all entered different phases of family visitation restrictions. Just last week, we went to one provider, one family member during the day, only model, but several months before that, we would not allow any family visitation because of surge in the community, and we were worried that the family members would bring in COVID and affect healthcare workers. Most importantly, I would say that, besides just the physician working group, our nurses took a lot of heavy toll because they worked tirelessly day and night, taking care of patients with neurological illness, COVID illness. So there was a lot of burnout. There was a lot of furlough and leaving of these nurses. And so we had to rely on traveler nurses, junior nurses, nurses with less experience in neurocritical care. And that potentially may not have worked in the favor of our patients, but we had to make use of the resources that we possibly had. Some of us reported that the patient presented late in their initial presentation, and especially in the first surge, because many patients were hesitant to come to the hospital because they were worried that they could get exposed to patients with COVID-19 disease and themselves get affected by that. Many hospitals report that our own healthcare providers tested positive for COVID. So they had to be quarantined, and other providers had to chip in and do the extra work. And then some of us reported that there was less exposure of students and residents to neurological cases and examinations. And this is interesting that, because we were kind of trying to cut down resources and keep only resources that were necessary for neuro and diverting everything to the COVID ICU, perhaps there was a missed opportunity there for those trainees to do a good neurological assessment or examination because of the restrictions imposed during the initial surge. Some of the positive takeaway from the pandemic. So it's not just gloom and doom. I think the pandemic also taught us a lot of things. So one thing is the virtual meeting. I think the reason I'm presenting to you today in a virtual format is just a testimony that we've can cross boundaries of international, national borders, because we can talk to each other and see each other in a virtual platform. Many of the hospitals were able to establish a new provider pool, create a backup pool, add equipment or space. And most importantly, we learned that we were able to cross-talk between different critical care specialties, pulmonary, general critical care, neuro, cardiac, whatnot. And we were able to interact with national and international experts. That was really good for us because suddenly the doors opened for a lot of collaborative research and efforts. And this study is a really true testament of how everybody came together, to participate in a global effort. Many of our providers said that they were more comfortable now during the pandemic and taking care of patients with COVID in managing the sickest patients. They were even trying to expose patients to newer drugs for sedation, which we never did in the past. We were more mindful of infection prevention practices. We all talk about hand hygiene, masking, PPE use. I think we are better at doing this now than maybe a year and a half ago. Tele-neuro ICU is the future. Many of us use telemedicine to advantage of our patients. And most importantly, resilience in the workflow. So we found that our workflow is really resilient. We built resilience. And I think the resilience was not just individually, but as a group. We saw our folks taking care of patients, taking care of family members, that increased our morale to some extent and boosted our morale and built more resilience in the workflow. And at least during the lockdown period, we saw a tremendous reduction in accidents and trauma victims. So maybe if we were to think, innovatively or creatively, we could use some of these measures to reduce trauma, victims or accidents, road traffic accidents, all over the world. I think this was a positive takeaway from the pandemic. When we asked some of our survey participants to quote and in their own words as to what they thought about key areas, so strengthening resilience, team spirit, and collaboration was a big one. So everybody said that everybody chipped in. They were never broke, but they tested their morale. Teamwork was great. Multidisciplinary work was great with RT, social work, rehab, physicians, nurses, and it brought the healthcare community together. And then everybody was kind of happy that the vaccination started in the late 2020, early 2021, and now our kids are getting vaccinated, at least in the United States to start with. So that's always a great news for us. It refined critical care skills. So this is important, that as critical care clinicians, we are always looking to improve our skill set. And the COVID pandemic gave us a lot of opportunities to do that. Importantly, our neurocritical care physicians thought that they could take care of medical ICU patients with the same competency as medical ICU or surgical ICU attendants. That was very important, that we got the recognition that probably was not available to us pre-pandemic. We can do it, we know that. So, telemedicine, like I talked about, is something that is worth exploring for the future. It's a great idea. Of course, it needs infrastructure and resources, but I think since the pandemic is here to stay with us, at least in some form in the future, and other things may evolve, I think it's good to invest in telemedicine capabilities. Opportunities for research, collaboration improved, and it was great to see great work coming with regards to COVID in the neurocritically ill patients. And then safe practice and hygiene, like I mentioned, was extremely important. And I think that will keep our patients safe and ourselves safe in flu and other seasonal disorders or illnesses that we frequently are up against. So in summary, I think what we found in the study was that independent of the country income level, there were some fundamental changes to neurocritical care delivery, including reduction in critical resources, testing, education, academic activities. And most importantly, I think it's acknowledged for folks is that the hospitals in low middle income countries were more likely to be insufficiently prepared and also struggle to return to pre-pandemic standards. Dedicated neurocritical units were less likely to be converted to COVID units. So we tried our level best to preserve the level of care, the high level of care to our neurologically sick patients. And of course, this all depended upon surges after surges. So if the hospital was in the midst of a surge, they were able to accommodate the non-COVID patients. But the pandemic continues to challenge our healthcare workforce, and it affected the morale. And we have some concerns about burnout. So we need to do a better job in proactively making sure that our healthcare workforce remains strong, safe, and we boost their morale as much as we possibly can. So with that, I really want to thank all my 253 hospital collaborators for a tremendous amount of time and effort that they have given me in making this study a great success. And I look forward to much more future collaborations with all of you for neurocritical care research. So I want to sincerely thank the organizers of the meeting to invite me and allow me to present this interesting work. Thank you and have a good day.